I want to dive right into one of the most controversial diagnoses in psychiatry: borderline personality disorder, BPD. Why has this label carried so much stigma, even among clinicians? And what damage does that stigma cause? I want to unpack how expectation shapes reality. When providers walk into the room expecting manipulation, they'll see manipulation. But when they reframe those same behaviors as survival strategies, they'll see resilience and maybe even help change the trajectory of someone's life and their treatment and their outcome. I also want to talk about the observer effect as a metaphor for psychiatry. Basically, what we believe about our patients changes what we notice, how we respond, and ultimately how recovery unfolds. Instead of fearing the word borderline, we challenge psychiatry to face the mirror and rewrite the story with compassion, precision, and hope. Borderline patients are the most difficult patients in psychiatry. Everybody knows it, but nobody wants to say it out loud. You can see it in the eye rolls when the diagnosis is mentioned in their chart from a previous visit or provider or inpatient stay, or when the client reports the history of the diagnoses themselves. You can see it in the way a chart note quietly labels them as histrionic or manipulative. You can feel the weight of the dread some clinicians sometimes carry with them into a session. If you've ever been on the receiving end of that diagnosis, you might already know exactly what I'm talking about. And if you're a clinician listening right now, I'm asking you to stay with me. Don't tune out yet, because this is the part nobody likes to admit. Our field doesn't just stigmatize borderline personality disorder, it actively teaches that stigma. We pass it down in training. We whisper it in the hallways. We pretend it's about the patients when really it says more about us than it does about them. Here's the thing. Borderline is hated because it doesn't play by psychiatry's rules. These people don't stay neatly in the box of a diagnosis. They don't stay politely in a 50-minute session. They don't always follow the checklist, recovery model that the system tries to enforce, and that terrifies us. Because if we're being really honest, borderline doesn't just challenge the people that we treat, it challenges us. Why? Why clinicians hate borderline personality disorder? Where that stigma comes from, what it means for the people living with it, and maybe most importantly, what it reveals about the cracks in psychiatry itself. And by the way, if you've ever wondered why borderline personality feels so much like an ongoing depression or low mood, or why it gets confused with bipolar or PTSD, we're going to come back to that in other episodes, because borderline doesn't just get hated on, it gets misdiagnosed, mislabeled, and misunderstood more than almost any other condition in psychiatry, which I have discussed superficially in other episodes and podcasts so far. But let's tackle one of the ugliest words in psychiatry: manipulative. If you've ever been diagnosed with BPD, you've probably heard that word attached to you or the diagnosis. Maybe not to your face, but definitely behind closed doors. It's the go-to label. Or maybe you've even embodied that spirit over time because you were told so frequently that you were that. They're just manipulative. They're just attention seeking. But honestly, what looks like manipulation is almost always survival tactics that have been learned. And when you zoom in, it's painfully obvious why that's true. One of the first lessons can occur in childhood. So picture an 8-year-old in a house where the chaos never stops. The parents are fighting, everybody's screaming, they're hitting each other. The only time the yelling dies down is when she threatens to run away. That's the moment people finally notice her. She learns at 8 years old that the only way to interrupt the storm is to say something extreme. It's not manipulation then. It's a tactic being used during a time of emotional desperation in order to survive moments that might feel unbearable then. It is survival. In that scenario, that's a last-ditch effort to influence the situation so that whatever desperation they are feeling will hopefully stop one way or another, despite the chance of them being criticized for their emotional outbursts later. BPD can look like impulsivity at times, and it can certainly also look like emotional reactivity. Now, imagine another child. She tries to tell her parents her uncle has been touching her inappropriately and just making her feel weird. She isn't believed, though, unfortunately. And maybe they tell her she's lying. Maybe they blame her for what happened. Maybe they punish her for even saying something like that out loud. So she learns that words won't keep her safe. The truth won't protect her. And then years later, when she's overwhelmed, she doesn't ask calmly for help anymore because calm communication never worked before. Instead, she cuts her arm open. Not because she wants to die, but because pain is the only language that ever made people pay attention. And what do clinicians call that? Manipulation. No, that's the nervous system screaming the truth that no one believed when she whispered it or didn't offer a large gesture of emotion until all the feelings had reached a tipping point. And then this can escalate into adolescence, because by the teenage years, the pattern is cemented. A kid has a screaming fight with her parents, locks herself in the bathroom, and sends a text. I'm done. I can't do this anymore. Parents roll their eyes. Clinicians roll their eyes. They call it drama. They call it theatrics. They say it's for attention. But if attention was the goal, then why does the same teenager end up in the ER with scars no one even knew about? That wasn't for an audience. That was just the only tool she had to regulate pain that was too big for her to manage. And then further into adulthood, that same individual might have the same strategies now because that's what they've learned. But now it's in a different setting. It looks different. This isn't a child or a teenager anymore. So fast forward, a patient texts their therapist, "If you don't call me back, I might kill myself tonight." On paper, it certainly looks like a threat, a power play. But if you zoom in, this is the same survival tactic that she learned at 8 years old. When chaos felt unbearable, the only way to feel safe was to go to the extreme, to do something or say something to garner a genuine reaction or what felt like one. It's not a chess move. It's not emotional blackmail. Sometimes it's just a terrified human being that used to be a little kid who learned how to cope in terrible ways. And now they keep using the only strategy that ever worked in their world around the people who didn't listen to them before. So when clinicians dismiss this as manipulation, what they're really saying is, I don't understand why this person has to scream to be heard. But the answer is simple: because they felt like no one ever listened before. Meaning they feel like they have to make these grand gestures to actually be heard. So now let's move on to talk about the piece that makes people, clinicians, the most uncomfortable, which is the suicidal ideation. It's the elephant in the room with borderline, with BPD, and it's where so much of the stigma sometimes comes from. The constant fear that the patient might kill themselves, or that they're just saying that they will. Clinicians will whisper, they don't really mean it. They're just doing it for attention. But that statement alone shows a dangerous misunderstanding of what suicidal ideation actually is. Because the reality of suicidal language is sometimes suicidal threats are intent, and sometimes they're not. But either way, they always mean something, because when someone blurts out, "I want to die," it's not always about carefully planning an ending. Sometimes it's just about not having any other words left and feeling hopeless. They're so hopeless, so flooded with emotion that their nervous system defaults to the loudest alarm bell it knows: suicide. They might even be beyond caring that people will judge them simply for feeling that way or for saying that out loud. It's clumsy communication, sure. It's terrifying communication, absolutely. It can be uncomfortable, but it's still communication. Saying, "I can't survive this feeling," in the only language that ever got anyone to listen, so they're just still speaking that language. I'm going to give you some real-world examples of this that might help you to understand better. So, a young woman argues with her partner. They threaten to leave, and she says, "Fine, I'll just kill myself." To him, it sounds like manipulation. But if you can zoom in to her, abandonment literally feels like death. The threat wasn't necessarily about control, it was about survival panic. A patient blurts out, "I want to die," mid-therapy session, then later admits they didn't mean it literally. They just couldn't find any other words for, "I'm drowning right now." And then here's something that is very important that I wanted to make sure we talked about. My mom has always told me that people with borderline personality disorder do typically tend to improve as they get older. So meaning they should struggle less with their symptoms of BPD as they age and as the years go on. And now I'm happy to report there is a growing body of research that supports this. The idea that BPD is a lifelong sentence has been challenged by long-term studies showing meaningful remission and recovery rates, which I think is just a reassuring thing because I know how hard it can be to struggle with BPD. But the natural course of BPD is that symptoms often decline with age. Impulsivity, self-harm, and intense mood swings are typically most severe in late adolescence and early adulthood, and then they gradually lessen. Interpersonal sensitivity and chronic emptiness may persist longer, but even these tend to soften over time. Remission rates are high. The McLean study of adult development followed BPD patients for over 10 years and found that about 85% experienced symptomatic remission, meaning they no longer met criteria for BPD at all at some point. Around 50% achieved sustained recovery, meaning both remission and good psychosocial functioning. So they were good in all areas. They were no longer BPD. They were cured, you know? Functional improvement lags behind symptom relief sometimes. Like many people see dramatic reduction in acute symptoms like suicidality and self-injury, but challenges in relationships, employment, or self-image may take longer to stabilize. But that makes sense considering a lot of those factors would be very habitual in nature and maybe more difficult to just kind of shift your mindset around. So maybe you're wondering, why do symptoms improve as people age? Why doesn't this happen with other illnesses? Research suggests several factors. Neurobiological changes are one factor because impulsivity and emotional reactivity naturally decline with the maturation of the prefrontal cortex. So as your prefrontal cortex gets more mature, that declines. You also learn from your experiences. Many people with BPD report that repeated crises eventually lead to new coping strategies or exhaustion of old patterns. Like they don't want to keep going to the hospital and fighting with people anymore. So they do differently. Treatment and support are big. Evidence-based therapies like DBT, which is dialectical behavioral therapy, or MBT, accelerate this improvement. It really helps whenever they do this. Survivorship bias in studies. Those who engage with care and survive into middle age often represent a group who has found more stability. So if they don't commit suicide and they get to that point, they can find stability. Some key studies found that long-term outcomes are steady improvement and high remission rates. Another found that borderline symptoms decline more sharply with age than other personality disorders. And another describes BPD as a disorder with a time-limited course rather than a lifelong progressive illness. So yeah, most people with BPD do get better with age. Acute symptoms tend to fade, and many achieve remission or even recovery. Though relational and identity struggles may persist, but with therapy and supportive environments, the trajectory is often far more hopeful than the stigma suggests. Okay, back to where we left off before I went off on that tangent. When we as clinicians decide, oh, they don't mean it, we're not just minimizing, we're gambling. Because here's the data. Around 70 to 80% of people with BPD will attempt suicide at least once. About 10% will die by suicide. The highest mortality rate of almost any psychiatric condition. So no, we don't get to just shrug and say, they're faking it. Even if the patient doesn't mean it literally in that moment, it's still a sign of deep distress and it still matters. Let's also be real, because suicidal thoughts don't just come from trauma. They often come from exhaustion, emotional exhaustion, an exhausted nervous system, maybe from walking on eggshells all the time. Living with borderline is just exhausting, honestly. The constant up and down moods, the black and white thinking, the emotional reactivity, it wears people down. The individual who is diagnosed becomes so drained from dealing with their existential crisis. People will tell me, I'm so tired of living with myself. I can't imagine how my partner feels. And honestly, that's exactly what it is. It's not always about wanting to die. It's about wanting relief from being at war with your own emotions and usually the people around you who you love the most every single day. And that's the other bitter pill to swallow. Just like it's exhausting for people to live this way, it can also be exhausting for the people around them, friends, partners, families, clinicians. That doesn't mean anyone's to blame. It means the toll is real on both sides, and the conversation has to reflect that. And the part where psychiatry shoots itself in the foot is we're so scared of the word borderline. Providers think, oh my God, if I say that, I'll lose the patient. They'll feel attacked. They'll feel critiqued and they'll be mad. It's too harsh. It's too stigmatizing. So instead, patients get handed 10 different labels: depression, bipolar, PTSD, but never the truth. And do you know what happens when you never tell someone the truth? They never get the chance to understand themselves. They never learn that these survival strategies can be worked with, that change is possible, and that silence is not protective, it's harmful. So yes, providers need to do better at breaking the stigma, but patients also need to hear the diagnosis without reacting like it's a moral judgment. Borderline isn't an insult. It's not an attack. It's a description of patterns that have roots in trauma, roots in survival. The dialogue has to change on both sides. Providers need to stop hiding, and patients need to stop feeling condemned. Because the truth is, honesty is what makes recovery possible. One of the wildest parts of this is that a lot of individuals with borderline personality disorder would actually benefit more from specific therapies, skills training, and behavioral modifications than they ever would from being trialed on most antipsychotics or benzodiazepines. Yet that's exactly what happens when providers dodge this diagnosis. Instead of DBT, schema work, or even basic emotional regulation strategies and coping skills, the person gets handed prescriptions for medications aimed at problems they don't even really have, as if emotional reactivity were the same thing as mania, or as if trauma-driven panic or PTSD panic could be solved with another benzo script. It's not that medications have no role at all, because they're often a useful adjunct, but when they become the centerpiece of treatment in place of therapy, the result can be more harm than help. Sedation isn't healing. Band-aids are band-aids. Polypharmacy isn't progress. And every time we choose silence over clarity, we rob patients of the chance to understand that their patterns can be reshaped. And real change is not only possible, it's actually probable. If we could stop whispering about it, stop avoiding it, and actually be honest about personality disorder traits and symptoms and life trajectories without judgment, they could actually improve. They could actually live better lives, not by hiding the diagnosis or avoiding it. When someone says, "I want to die," don't roll your eyes and don't dismiss it. And don't hide behind silence either, because whether it's a survival scream, plea for help, or a serious plan, it always means something. And the only thing more dangerous than hearing it is pretending it isn't there. Now, let's talk about something most clinicians won't admit. Borderline personality disorder makes us uncomfortable because it shows us parts of ourselves we don't want to see. So this is where the mirror effect comes in. When a patient screams, "Don't leave me," it can feel irritating, even manipulative. But if we're honest, how many clinicians secretly feel the same thing in their own relationships? The terror of abandonment, the need to be reassured, the anger that bubbles up when they feel ignored. Borderline people don't invent these feelings, right? They just express them out loud. And that's what makes them so hard for us to sit with, because they hold up a mirror and suddenly the room doesn't feel so professional anymore. It feels personal. Personality disorders pull at the cracks in our personalities. They stir up helplessness, frustration, anger, emotions that we're trained to suppress. Most clinicians have abandonment fears. They're just human. Most have felt rage. Most have struggled with rejection or emptiness. But we were taught to shove that down, to keep it out of the room. So when a patient embodies it openly, we don't know what to do with it. Instead of saying, "That's human," we label it as disordered, and we hate the person for reminding us what we try to hide in ourselves. Think about it. A patient with major depression can say, "I feel worthless," and clinicians respond with compassion. A patient with borderline personality disorder says the exact same thing, "I feel worthless," but with tears or anger or a frantic text message, and suddenly it becomes manipulative. The symptom is the same. The difference is in how it makes us feel. And instead of owning that countertransference, we pin it on the person, on the individual. So borderline is hated not because it's untreatable, but because it's unignorable. These patients don't let us stay detached. They pull us into the storm, and that terrifies a field that survives on detachment. Psychiatry has built its walls around the idea that we can stay objective, but borderline personality keeps climbing over those walls and shouting, "Hey, I need you to actually see me." And the truth is, many clinicians don't want to be seen either, so they push that patient away. If you hate borderline, maybe what you actually hate is your own reflection in it. And here's where it gets interesting. Think about the mirror effect we just talked about. Quantum physics tells us reality isn't fixed, that observation itself changes outcomes. The act of observation changes how particles behave. In other words, what we expect is partly what we create. If a clinician goes into a session expecting manipulation, they'll see manipulation. If they go in expecting survival strategies that can be healed, they'll see survival strategies that can be healed. We are literally co-creating reality with our patients in the room, which means we can either reinforce the stigma or shift the whole trajectory of someone's life by changing the lens we're looking through. In the famous double slit experiment, when particles weren't being observed, they behaved like waves. Fluid, expansive, unpredictable. But the moment they were observed, they collapsed into particles, fixed and limited by the act of being watched. So the myth that borderline patients are manipulative is false, because what looks like manipulation is survival. And when you follow the thread, it usually started all the way back in childhood to that 8-year-old girl we talked about, screaming, self-harm, suicide talk, as the only way to get someone to pay attention to her. That's not a game. Longitudinal, long-term studies show that most people with borderline symptoms improve significantly over time. Remission rates as high as 85% at 10 years. But stigma keeps people from getting the treatment they need. It's not the patient that's hopeless, it's the system. And if we zoom out for a minute, the hatred of borderline patients isn't just personal, it's historical. Psychiatry built it this way. The DSM plus the untreatable legacy of borderline personality disorder first showed up in the 1980s. Before that, clinicians used the word borderline as a kind of insult, meaning you were on the border between psychosis and neurosis, which translated to confusing, messy, not fitting anywhere neatly. We need to put it somewhere in a box. By the time it got formalized as a diagnosis, it carried decades of baggage already. Untreatable, unstable, hopeless. That history still shows up in how clinicians are trained to this day. Most residents and early career therapists don't learn borderline through compassion or through that type of lens. They learn it through the warning labels. They're told, watch out for these individuals. They're manipulative. They'll drain you. They'll threaten suicide. And where do they learn that? From their preceptors, from the people that come before them, from the generation before them. It gets handed down like clinical folklore. These patients are impossible. Don't get too close. They'll burn you out. That narrative repeats itself because nobody stops to examine it. Nobody pauses to ask, wait, is this even true? Personality disorders get written off as lost causes before we've even tried to understand them. The system is kind of set up for people to fail with the short appointments, insurance companies demanding quick fixes, denying therapies, overbooked caseloads. Borderline individuals don't fit in that system. They don't get better in 15-minute medication checks. They don't stabilize in 6 therapy sessions. So clinicians and providers end up overwhelmed, resentful, and burnt out. And instead of blaming the system, we blame the patient. We blame the individual. We label them as impossible when really they just need what the system refuses to give, which is time, consistency, and trauma-informed care. Borderline isn't hated because it's a hopeless diagnosis. It's hated because the way psychiatry is built makes it impossible to treat it properly. And instead of fixing the system, we take it out on the people living inside of it. We can talk history, we can talk systems, we can talk quantum physics, but at the end of the day, this stigma lands hardest on the patient. And if you've ever carried a borderline diagnosis, you know exactly what it feels like. You know exactly what I'm talking about. It's being dismissed before you even open your mouth. It's walking into a room and realizing somebody already decided who you are. It's living in a body that feels like a battlefield and being told you're just too much. Another example is a woman shows up in the ER after cutting herself. She's bleeding, terrified, exhausted, regretful. The nurse glances at the chart and mutters, "Oh, she's a frequent flyer." The doctor rolls their eyes and she feels it instantly. The disgust, the dismissal. Instead of safety, she feels shame. Instead of care, she gets contempt. And the message she leaves with is the same one she's always carried, which is just kind of like, she's not worth saving. Or imagine a patient storms out of a therapy session in anger. The clinician sighs, takes notes, and moves on to the next appointment. But in the car, the patient is sobbing, thinking, "See, I ruined everything. I can't even keep a therapist." So what looks like drama from the outside is really just devastation on the inside. And then there are the patients who never even get the name. They bounce from diagnosis to diagnosis: depression, bipolar, PTSD, anything but borderline, because we don't want to say it. Their providers avoid the word because it's too loaded. And without it, those patients spend years confused about why nothing fits, why nothing works. They get half answers instead of the full truth. And in the end, that silence is its own form of abandonment. Part of the reason borderline gets hated is because it looks so much like other disorders. The persistent low mood looks like depression. The mood swings look like bipolar disorder. The trauma symptoms look like PTSD. The overlap is real and it's messy, and we're going to unpack that in its own episode soon. But right now, what matters is people aren't crazy for feeling dismissed. The stigma is real. The damage it does is written into their lives every single day. If you've ever been called manipulative, dramatic, impossible, hear this. You are not the monster psychiatry has made you out to be. You are a human being carrying unbearable pain at times in a system that doesn't know what to do with you. And if clinicians could drop the eye rolls long enough to actually listen, they would see it too. So where does all of this leave us? Right now, borderline personality disorder has been treated like psychiatry's dirty little secret for decades. The diagnosis everyone whispers about, the people everyone dreads. But here's the truth. The hatred isn't really about the patient, right? It's not about the individual. It's not even about the borderline personality disorder. It's about us, about our discomfort, about the failures of our system, about the mirrors we don't want to look into. And something else to think about, borderline is one of the few personality disorders that clinicians actually give to children and teens. That means a kid can carry this label before their brain is even fully developed. And once it's there, it follows them. Every ER visit, every new provider, every intake, that word can sit on their chart like a scarlet letter. Schizophrenia and bipolar are almost never diagnosed in children that young. But borderline, we put it on kids, and then we wonder why they grow up already believing they're doomed. So if you're a clinician listening, I want to challenge you. The next time you feel that dread when you see borderline personality disorder or BPD on a chart, stop and ask yourself, is this about the patient or is it about me? about my own fear of failure, about my own hidden anger, about my own unresolved need to feel in control. If we don't ask those questions and look at ourselves, we end up punishing people for being human in ways we just don't want to admit in ourselves. And if you're a patient listening, I need you to hear this. You are not broken beyond repair. You are not manipulative by nature. You are not a lost cause. The strategies that people call manipulative were survival tactics you built in order to stay alive in the environment you were in, and they worked. You're here. You survived. And that means that you can learn new strategies too, ones that aren't about crisis, ones that don't drain you or the people around you, ones that let you actually rest. Recovery doesn't mean you never feel deeply again. It means you stop being at war with yourself. Borderline isn't a hopeless diagnosis, but the way psychiatry has treated it has been hopeless. And that's what has to change. The dialogue, the honesty, the way we come with it, the way we stop hiding behind silence and stigma and actually start telling the truth. Okay, that's all for today. Thank you for being here and thank you for listening. And I'll see you next time. Bye.